Alright, we'll address here the very important appendicitis. And appendicitis is one of the most common surgical emergencies in the United States, and absolutely, quintessentially, an essential on your differential for abdominal pain, especially if it's right lower quadrant abdominal pain. The incidence of appendicitis peaks in young adults, but the diagnosis of appendicitis should always be considered whether it's a young child or if it's an elderly adult. There is a slight male preponderance, and the reason for that isn't really known, but appendicitis is common among all groups, all racial groups, all age groups, both sexes, etc., etc. Usually, appendicitis is due to obstruction of the appendiceal lumen by what's known as a fecalith, and that's just a calcified and hardened piece of fecal matter. And what happens is that gets obstructed into the appendiceal lumen, and when you have obstruction of the appendiceal lumen, you get two things. You'll get bacterial overgrowth because there's no more communication between the appendiceal lumen and the cecum, and you'll also get some swelling and edema because the pressure in the appendiceal lumen increases. So those two things are going to result in inflammation and ultimately pain. There's a higher incidence of appendicitis in the Western world compared to the Eastern world, and that's more than likely due to a lower fiber intake because of our processed diet here. And when you have less fiber in your diet, you're going to have a longer transit time, and that encourages the development of these fecaliths. And you're also going to have a more sludgy stool. Or more sludgy material in your small intestine and in your cecum. So both of those encourage development of fecaliths. So that's likely what's behind the higher incidence in the U.S. So another reason to get your 20 to 25 grams of fiber every day. 90% of Americans don't. Okay, now it should be remembered that the classic acute appendicitis is a separate entity from what's known as missed appendicitis, and it's going to demand a somewhat different approach to treatment. So as a rule of thumb, acute appendicitis is usually the diagnosis when the pain is recent, like in the last several hours or in the last day, especially when the patient hasn't yet sought prior care. So acute appendicitis is usually the person who's coming in with a right lower quadrant pain, and they haven't been in before. This is something that's very recent, within the last several hours. Missed appendicitis is usually our fault. And usually what missed appendicitis is that the pain came on some time ago, usually a day, 2 days, 3 days ago. Maybe the patient came in and they were discharged with the diagnosis of maybe gastroenteritis or something that's not appendicitis. And the pain has continued, and now they're coming in again and wondering why their pain hasn't gone away. Maybe they have a fever, a continued fever. Maybe they don't because they're taking Tylenol or Advil or something for the pain, which is also an antipyretic. But what's most important is that these patients have had a longer pain. They've had pain for a day or 2 or 3, and it's classic for appendicitis, but they've had their pain for a longer period of time. Now, sometimes with patients that have appendicitis, and eventually anytime really in patients who have appendicitis that goes untreated, what will happen is the appendix will rupture. Remember that you're getting swelling of the appendix, and it can only swell so much. So what's going to happen is initially when you have appendicitis, you're going to have right lower quadrant pain, but then once it ruptures, now that you don't have all this pressure in the right lower quadrant anymore, the pain will sort of resolve a little bit for a few hours, but ultimately what will happen is that it will go into a diffuse abdominal pain. This is peritonitis, and that's because you now have inflammation in your entire peritoneum. So that's sort of your natural history of appendicitis. But it's going to be important to remember that very, very, very early acute onset appendicitis is a somewhat different animal from the missed appendicitis, where it's been going on for more than 24 hours, especially if the patient has already been in and was discharged with a different diagnosis and their pain has continued. Okay, so the symptoms of acute appendicitis. Early on in appendicitis, you're going to have onset of right lower quadrant pain, and that pain is going to lead, in most cases, to nausea and vomiting. Pain often just causes nausea and vomiting in general. That's not really specific to appendicitis, but what is important to know with the nausea and vomiting is that with appendicitis and some other entities, the nausea and vomiting follows the right lower quadrant pain. Whereas with if you have nausea and vomiting that precedes the pain, then that's more than likely some kind of small bowel obstruction. So a little bit of clinical advice there. So nausea and vomiting should follow the right lower quadrant pain in appendicitis. Anorexia is common just because of the pain. A lot of people who have abdominal pain aren't going to want to eat. And fever is something that you'll certainly see in most patients with appendicitis. Okay, physical exam, you'll have pain on palpation of the right lower quadrant. This point that you get the most pain is called McBurney's point, and it roughly coincides with the point that overrides the appendix. You'll also have rebound tenderness and guarding, and that's just sort of localized peritonitis, localized inflammation over that area. Another thing that you can do to look for this sort of pain that you have in appendicitis is called the pinch and inch sign. So what you're doing is you're just pinching a little bit of the skin that's over McBurney's point and then letting it go. And that's a lot of times easier to do than checking for rebound tenderness, which is kind of I wouldn't say difficult exam, but cumbersome. So that's just my own little guideline. But rebound tenderness and guarding is something that you'll have over the right lower quadrant. And then psoas sign and obturator signs are things that you can find also in your physical exam. So McBurney's point is found by locating the right anterior superior iliac spine, which is easy to do in patients such as this who are nice and fit, but can be a little bit more difficult to do in larger patients. You'll palpate for that point, and then the umbilicus should be obvious, and it's 1/3 the distance from the anterior superior iliac spine to the umbilicus. And so this is the point where you're going to be looking for the pain, looking for the rebound guarding or rebound tenderness and guarding. Psoas sign is done by just having the patient roll on their left side, and you're just pulling the leg back. And that should increase pain in the right lower quadrant. Obturator sign, you're just flexing the leg at the hip and abducting the leg at the knee, and that also should cause increased pain at the right lower quadrant. All right, so your differential for right lower quadrant pain, in addition to appendicitis, should include Meckel's diverticulitis, which I'll show. This will be at the very end. I'll show you this is pretty much the exact same thing as appendicitis, but it is a sort of distinct entity. Inflammatory bowel disease, that should be set apart by sort of a more chronic pain that's come and gone, and they usually have blood in their stool. Hernia incarceration will be diagnosed on imaging. Renal or ureteral stones, this is a little bit different. Right lower quadrant pain, this pain usually radiates to the back, and it also should radiate down to the groin and down the penis in a man or to the vulva in a woman. Of course, in women, OBGYN problems are always things that we're considering when there's lower abdominal pain and pelvic pain. So certain things would be ovarian torsion, of course, ectopic pregnancy, which is really important to remember in a woman of childbearing age, pelvic inflammatory disease. They usually have a history of STDs, salpingitis, and tubo-ovarian abscesses. So these are all on your differential for right lower quadrant pain. Labs that you should be getting. So when you suspect appendicitis, of course, you're going to be getting labs, and labs are going to help you. And the labs you're going to be getting are things that help you differentiate these. So CBC, what do we think of in appendicitis? We have inflammation, so we should have increased white blood cell count. CMP should be normal. Urinalysis, this is done primarily to, I didn't put it on here. Okay, this is done to rule out some other things. So you may have a bladder infection. So if there is a bladder infection, your urinalysis should come back reflecting that. And then a beta HCG. This is of the utmost importance to get in women of childbearing age. So roughly, I would say, between the ages of 13 to 55 years of age. You might want to expand that just to be safe. The beta HCG test is important for 3 reasons. 1, if it comes back positive, you are going to think possibly this may be an ectopic pregnancy. Now, pregnant women can get appendicitis too, so it doesn't rule out appendicitis, but you can't exclude ectopic pregnancy then. 2, if the woman is pregnant, then there are other ways for appendicitis to present. Women who are more obviously pregnant, especially after the 4th month, they may actually have right upper quadrant pain just because of when the fetus gets big enough and moves up into the abdomen, the appendix gets displaced. So that can cause right upper quadrant pain. So that's also the important thing to think of. You might not have to get a beta HCG in an obviously pregnant woman, but I just wanted to bring that up. And then thirdly, for management, women who are pregnant, you're going to be giving them different antibiotics. Okay, so as I mentioned, labs, CBC should come back with elevated white count and a left shift, but not necessarily if it's very early on. CMP is usually unremarkable, urinalysis is usually unremarkable, and then your beta HCG is usually unremarkable. But as I mentioned, pregnant women can get appendicitis too, and there are other things that the beta HCG may imply that can affect their management. All right, now, what do we do if we still suspect appendicitis? If the diagnosis of appendicitis is very likely, based on your history, your physical exam, and the labs that you just got, then the best initial diagnostic step is an abdominal x-ray. And what we're looking for here is the fecal lith. And the fecal lith is usually you can only find the fecal lith in about, I'd say, 5 to 15% of patients. And so most of the time, the abdominal x-ray is going to be unremarkable. Of course, your radiologist is going to read this. So, but anyhow, if you don't see the fecal lith, you need to still work this patient up for appendicitis, because most of the time the abdominal x-ray will be unremarkable. So if the abdominal x-ray is unremarkable, then you'll just go on to get a CT with contrast. Now, the reason that we get an abdominal x-ray in patients with very obvious acute appendicitis is because you may find the fecal lith. And if you find the fecal lith, then you've already gotten your diagnosis, and you don't have to go through with getting the CT, which is very expensive. So if the diagnosis of acute appendicitis is very likely, your next step is an abdominal x-ray. If the diagnosis of acute appendicitis is questionable, based on history, physical exam, and lab, so maybe if the patient doesn't have a fever, they don't have an elevated white count, if maybe they don't have the rebound tenderness with guarding, but they still have right lower quadrant pain, then your best initial diagnostic step will be to just go straight on to the abdominal CT with contrast. Abdominal CT with contrast is your most accurate test, and it's got almost 100% accuracy. Pretty much just limited to the skill of the interpreter. So here's an abdominal x-ray with a fecal lith, and this is a really big fecal lith, really obvious one. You're not going to see these most of the time, but you still get abdominal x-rays just because in the roughly 1 in 8 chance that you might find it, then you've already got your diagnosis. Okay, so here's a CT of a normal appendix. Now remember, I said get a CT with contrast, and the contrast is the important part, because what we're looking for is, in a normal appendix, the contrast will fill the appendix. It'll fill the appendiceal lumen. In appendicitis, we have blockage of the appendix, and so what you're going to see with appendicitis is no contrast in the appendix. And here would be a case of that. So here is your cecum right here, and your appendix is down here. This is your appendix right here. And that would be no contrast in the appendix. It's also somewhat inflamed, so it's usually not that big. So you got inflammation of the appendix and no contrast. I don't expect you to get asked questions just looking at a CT for the USMLE, but for clinical purposes, this is useful. Okay, so here's the appendix here, and you don't see any contrast. But here's your contrast here in your ascending colon. All right, so once you've diagnosed the patient with appendicitis, which is done on imaging, then the next best step in management is going to be appendectomy. And this should be done within the next 24 hours, but it doesn't need to be done absolutely emergently. So most of the texts say emergent appendectomy. That does not mean that you're calling the surgeon on call and wheeling the patient in to save their life for appendectomy. So what they mean by that is appendectomy within the next 24 to 36 hours, but you will be admitting them. So also included in the admission is going to be, of course, admission and IV fluids, which usually you start prior to, because most of these patients come in appearing somewhat dehydrated. You'll have them NPO for the surgery. Broad spectrum IV antibiotics, especially covering those gram-negatives and anaerobes, which may spill out into the peritoneum if you have a rupture. And then oxygen and pain medication. There have been some people who've said that pain medication shouldn't be given very liberally to patients with appendicitis because it might make it difficult to diagnose the appendicitis. That's false. So they should be given pain medication. It's good to treat your patients timely. And if you do have negative CT findings, which remember, CT is very, very, very good at diagnosing appendicitis, then that should prompt suspicion for other diagnosis. Okay, now the missed appendicitis. So this is the patient who's had a longer onset of symptoms, or they came in before and with symptoms consistent with appendicitis, but they were sent home. So the history for these patients are recent symptoms consistent with acute appendicitis, which remember would be the right lower quadrant pain, nausea and vomiting, anorexia, and fever. And what are they going to come in with? Well, they're going to have ongoing abdominal pain that hasn't gone away. It can be centered on the right lower quadrant, or it can be diffuse, which would suggest a rupture. They may also, they'll usually have nausea and vomiting because of the pain. They may not have fever because a lot of these patients have been taking Tylenol or Advil or what have you, and that lowers your fever. So they may not have fever when they come in like this. On physical exam, they should pretty much have all the same things that you would see with early appendicitis. So pain on palpation of the right lower quadrant, guarding and rebound tenderness of the right lower quadrant, psoas sign, obturator sign, but they may have generalized guarding and rebound tenderness, and that would suggest a rupture. Same thing here. Best initial diagnostic step is going to be to get the abdominal CT. And so here's an appendicitis with an abscess, and so it's kind of hard to see here because the inflammation is sort of lighting things up a little bit, but here would be where your appendix would come. This is your right here, this would be your cecum, and then this is the beginning of the appendix. This arrow keeps going away on me. Okay, and then this is your abscess and inflamed appendix. I don't expect you, again, to be asked anything just looking at a CT, because The appendix is in variable positions in different people. Sometimes it can be retrocecal, sometimes it can be in other positions, and so this is really something where your radiologist is going to help you out on. But this is classic appendicitis with an abscess. Here's another appendicitis with an abscess. This is a big abscess here. So here's your where your appendix comes off. This is an abscess. You can even see that there's air in the middle of it, which helps you confirm that it's an abscess. And then here's a fecalith down here. All right, so once you have confirmed that this is appendicitis, but that it has been going on for a long time, it's missed, there's an abscess, then you should admit the patient, place them on NPO, broad-spectrum antibiotics, etc., but you're not going to do emergent surgery. You're not going to do surgery yet. Why? Because they have significant inflammation, and you don't want to do surgery on patients who have those abscesses if you don't have to, because what you're getting here is the body's natural immune system coming in and trying to wall off this appendicitis. And a lot of times it can do that successfully. And you don't want to go in and try to have to cut this out of the patient if you don't have to right away, because you can create more problems. And so what you want to do is observe them to see if their fever and their white count and their pain go away. And in a lot of times it does. So what you're going to do, if missed appendicitis is the diagnosis, is that you should admit them, put them NPO, broad-spectrum IV antibiotics, just like what you would do in patient with the early acute appendicitis, and then observe them with serial CTs and labs. And you're looking for signs of no rupture and for the walling off of that abscess, and you're also going to be looking for the pain and fever and white count to subside. If the pain and fever subside, you can discharge the patient, but they need to return for an appendectomy in 6 to 8 weeks. And what you're just looking for here is just, what you want is for them to cool down so that you're not operating on an acutely inflamed patient. If the pain or fever worsens, or if that pain is generalized, if they have peritonitis, then the patient needs to be taken for laparotomy and peritoneal lavage to clean out the peritonitis. And if a right lower quadrant mass develops, then the patient should be taken for CT-guided percutaneous drainage. So appendectomies today are almost always performed laparoscopically. If the appendix is found and it does not appear to be inflamed, it should be removed nonetheless, but you should go 2 feet down the ileum proximally and look for a Meckel's diverticulum. Remember Meckel's diverticulitis? It looks just like appendicitis. A lot of patients don't know they have a Meckel's diverticulum, and when it gets inflamed, it presents just like appendicitis. And if your radiologist wasn't looking too closely, or if it was in a confusing spot, it can look just like appendicitis. And so you're going into the patient, if they have the diagnosis, presumed diagnosis of acute appendicitis, you're going to cut that appendix out, but you're also going to look for a Meckel's diverticulum. And if you find one, obviously you're going to remove that. And then complications from appendectomy are adhesions and then general surgical complications. So this is an appendectomy, a laparoscopic appendectomy being done with the tools here. And then here is the appendix being taken out. The appendix is very long, and this is a technique known as a spaghetti technique, and what they're doing is they're taking the tool and they're just wrapping the appendix around the tool, and it makes it easier for them to then cut the appendix and then ligate it. Okay, this is me. This was shortly after I got out of medical school, came home for the summer, was going to be on break for a little bit, and Shortly after I got home, I think not more than a day or two, I was out with my friends and got some pain in my right lower quadrant. Knew at the very spot that it was appendicitis after 4 years of medical school. And went in, yes, it was appendicitis, and I had many complications. I wound up getting an abscess after my appendicitis, where the incision was for the laparoscopy. I was retaining urine. It was a nightmare. So here's me not too happy. But remember to be kind to your patients, because someday you will end up one. This was my very first time ever having to be in the hospital. So it was really strange being on the opposite end of things. And with that, I bid you farewell for now.